Good afternoon, everyone, and welcome to this very special episode of Ben's Den, which is our monthly podcast series where we cover all things that matter in healthcare with the people who matter. Since this is the annual episode for the year, we decided to mix things up a little bit and host it live for the first time with the virtual audience, and also decided to invite a panel of experts to join me and not just one individual, which is our regular cadence. So first, I want to thank you all for taking the time on a busy afternoon to join us. But before we start, I do want to take a moment to reflect and decry the senseless act of violence that took Brian Thompson's life, the CEO of United Healthcare, just a few days ago. There is no justification for violence in our society, regardless of how much we believe our system to be broken. And amidst the avalanche of rage and glee that followed, shockingly some glee from some corners, all of us at the garage offer our deepest condolences and support to Brian's family and all his colleagues at United. So with that, we have a lot of important topics to cover today, but let's kick things off by introducing our panel. The three guests today are not only three of my favorite people on the planet, but they're also change makers, champions in their own way, and dedicated to improving healthcare for all our patients. It is an absolute honor to host them, and I'll let them introduce themselves. So why don't we start with Joe Taylor? Joe, why don't you go ahead and introduce yourself to our audience?
Hi, everyone. Joe Taylor. I get to do a couple different things, but in this role, I am the president of the Community Care Collaborative. We're an ACO out of Philly, and we have about 17,000 Medicare MSSP lives, generated about 8% insured savings last year. Since 2017, we've generated shared savings every year. 2017, we didn't get enough shared savings to get paid. However, all the other years we've gotten paid in shared savings. And then we have about another 40,000 in other value-based contracts with various payers, the Aetnas, the Cignas, the local Blue Plan, and so on.
Thank you, Joe. Mary?
Hi, Mary Zelazny. My day job, I'm the CEO of a community health center program in upstate New York. We're in a rural part of the state, and we serve about 29,000 patients. And I'm also the board chair of our IPA, forward-leaning IPA, and we represent about 350,000 lives across upstate New York, and we're in some value-based contracts. And what's interesting about the IPA is that it is FQHCs or community health centers, however you want to call us, behavioral health centers, and a rural health network with public health departments and some other community-based organizations, integrating care together to try to do well on our contracts.
Thank you, Mary. Last but not the least, Himadri.
Thank you, Pranam. It's an absolute honor to be in this webinar in Ben's Den, and absolutely humbled to be among such esteemed panelists. My name is Himadri Sarkar. I'm the Chief Solutions Officer for Teleperformance. Teleperformance, as most of you would know, is a global leader in customer experience management. We offer outsourced services across various industries. We have a total strength of about 500,000 people. We serve across 80 countries and in 256 languages. In healthcare specifically, we provide very tailored solutions for patient engagement, claims management, and a host of operational efficiency interventions to improve care outcomes and to reduce costs.
Thank you, Madhuri. Thank to all of you for joining me today. As we all can see, three different personalities with a common objective to change healthcare for good. So with that, let's dig into some very important conversations that we need to have. We are coming to the end of what has been a very eventful year for healthcare and beyond. So this is a question to all of you. So 2024, how do you look back at it? What are the top three takeaways? Joe, I'll start with you.
Okay, so one of the things that was really interesting coming out of the end of 23, going into 24, was around the fraud within the Medicare space, the traditional Medicare space. And you probably all heard about the catheter issue and what that cost different ACOs. But we also went through and designed with the garage what we call our CPU dashboard. Cost is equal to price times utilization. where we're much more able and facile to analyze what's going on at the CPT level to see if anything's increasing more than X%, either through volume and or cost, so that we can see what's going on. And we've already reported 2 different areas of fraud based upon our claims data for 2024 data. And so if you're looking at your data, you really got to just keep that in mind. There's a lot more there than just the catheters. The other big thing from 2024, and I just got off the call from a payer looking at our 25 contract, but Medicare Advantage profits, or maybe I should say lack thereof, is translated to little or no shared savings for ACOs and our doctors. And that's problematic because we're doing the stuff to get the quality forms, the STARS ratings, the validation of chronic conditions. And so if there's no shared savings, there's not a lot of money to pay them. And so we've been looking at 24 in saying, how do we reinvent those contracts in such a way that we know the payers underwriting or whatever it was didn't produce shared savings? So how do we get paid for our activities that generate a lot of value? And then for community hospitals, profits are really tough. And I know there's some other folks here who probably are even in a tougher spot, but the organization that I work for that owns the ACO is a community hospital, and they're having very difficult financial times. The money we make from our value-based contracts is essential to our success and survival moving forward. And so going back to the first 2, it becomes really important. Got to deliver the quality. We've got to get the coding, but we have to be successful on the bottom line as well. And so those are our big takeaways from 24. If we can do those things, get rid of the fraud, if we can find a way to make money off of the Medicare Advantage payers and then deliver value to both the physicians and to the owners, then we'll be successful.
Thank you, Joe. Mary?
Number one, I think one of the big things that we face, so we're a community health center program, and across the country, we serve a huge segment of the population, about 1 in 10 Americans. But health centers are in financial trouble in a lot of cases because we are not getting reimbursed by payers even close to our costs. We did a study in New York State of all the health centers in New York State, and we're only getting 70 cents on the dollar of our costs. So we provide primary care. Our model is medical, dental, behavioral health in one setting, and also wraparound services, and we just don't have that ability anymore. And so it's putting a lot of pressure on the primary care system, particularly in smaller communities, rural communities, or underserved communities. And we're not the last resort, we're the only resort in many instances. And so where does that leave people if we have to close down services, right? So that's one thing that has really been a big takeaway for me for 2024. The promise of artificial intelligence has been fantastic. We have, as everybody's had in the healthcare system, workforce is a big problem. It's a little better, but it's still really hard. People shift around and move, and it's really difficult. And we get a lot of pressure in the health center world because we get new providers, we train them, and we put a lot of effort into them. And then the big hospital systems come and yank them and offer them a little more money, and we lose them. So it's been a real challenge. But with AI, we've been able to mitigate a lot of those mundane tasks that take a lot of power, human power. But at the same time, there's a lot of concern because we don't really know. I mean, it's an untested field yet for a lot of us. So we're trying to understand where are our boundaries, what do we need to know, what do we need to understand. So that was a big thing. And then, all these great innovative tools in my health center, I push innovation all the time, telehealth technologies, anything we can do to use technology to better help our patients. However, it requires internet. And the huge digital divide as already in a lot of particularly marginalized communities, but in rural communities. And I really worry about as we rely more heavily in the healthcare system, look at the hospitals at home. If you don't have internet, it's useless, right? So we're really concerned. That's been a great thing, all this innovation, but it does present a big challenge for a lot of communities.
Mary, I'm intrigued by your 70 cents on the dollar analysis in the state of New York. Is that because cost and demand has gone up, or is it because reimbursements have gone down?
the reimbursement for Medicaid, particularly in New York State, they have put these artificial ceilings on our how they figure out our payment structure, and you just you hit the ceiling. We're at every ceiling. Every health center I know is at every ceiling, so it's a very challenging problem.
Thank you, Barry. Himadri?
It's very interesting to go third because there are so many ideas that I can actually be inspired, and a lot of the takeaways that I'm going to talk about would probably reflect on what Joe and Mary covered. So really the first takeaway for me was our continued shift towards value-based care models.
Yeah.
And when I talk about that, it's essentially the risk-based stratification to improve care coordination. If we have to take an example about providers whom we work with very extensively, how we can have high-risk patients to prevent readmissions. For payers, like Mary touched upon, we are also helping design tailored reimbursement strategies for payers. The second takeaway is I think the health ecosystem continues to be more and more consumer centric, which is where it is demanding personalization, at the same time convenience and transparency. And some of the use cases that continue to emerge are telehealth, real-time patient engagement, and also personalized treatment recommendations. And there's a lot of work that we are actually doing and pioneering and partnering now with Pranam and his group. The last bit is something that I think we are all familiar with, which is all about focusing on operational efficiency. And we're also seeing a lot of workforce shortages amongst caregivers and healthcare staff, which is also causing a lot of burnout. And which is where I think Mary and Joe both touched upon this, which is how we can automate some of the administrative tasks. In the case of payers, maybe claims processing, fraud detection. In the case of providers, right from appointment scheduling to documentation to resource allocation. Those pretty much, Pranam, in my mind, were my takeaways.
Thank you, Himadri. And let me stay with you, right? And Mary mentioned AI, you mentioned AI. Let's put AI in the spotlight. From my perspective, there was a lot of buzz around AI in healthcare in 2024, pretty much talking point in every circle. Yeah. What is your POV on it, Himadri? Where do you think we are as a industry in truly adopting AI in a way that it's effectively regulated? Because that's the bigger concern around more than the tech, right?
Absolutely, yeah.
Because you look at social media, which has been around for 2 decades or more, and that's gone unregulated. And AI, which can potentially be a lot more powerful, especially in healthcare. How do we come at regulating its adoption? Your thoughts on it?
Pranam, a very pertinent point that you've touched upon. I think there are ample opportunities that at least my organization and I are seeing in terms of its mainstream adoption. But to your point, it needs to come across with some guardrails.
Right.
So I'll kind of talk about what are those use cases and what are those guardrails very briefly. I think the first one probably is how we can protect patient trust by ensuring compliance with HIPAA, and which is where data privacy and security comes to the forefront. When it comes to payers, some of the use cases that we are working with that kind of a guardrail is predictive underwriting and fraud detection. For providers, we're also looking at generative AI tools for clinical decision support. Have we got nirvana with it? Of course not. It's a very evolving use case. The other one that we're also looking at is how we can truly leverage AI with human oversight. And this human oversight is essentially important to avoid the errors and the biases that tend to come in if you're just administering AI. Again, as an example, for payers, most of the claims adjudication today is automated. However, there is merit in terms of having human auditors to validate some of those flagged anomalies that happen many a times due to algorithmic bias, and we are familiar with it. I mean, we all face it. Just a third point or use case in terms of mainstream adoption could be AI can never be successful unless and until, even before we implement, we look at how we can drive a cost and a workflow integration feasibility. By that I mean that if you think about payers, yes, you can have service chatbots as a point of interface for members, but we'll also have to see how well it integrates to the CRM systems.
Right.
Similarly, in the case of providers, we can have scheduling tools that integrate with the HRs to optimize patient workflow. But we'll also have to kind of see that it should not require too much of an extensive training on new infrastructure. Because if there is a lot of upfront investment, then somehow the adoption of AI can be, marginal and not as much as we would like to propagate it. So that's where I feel that, the mainstream adoption is going to happen. There would be guardrails, but because of those reasons, it is also attracting a lot of VC investments.
Got it. Thank you, Himadri. And Joe, coming to you, Himadri mentioned more BBC, and that has been our experience as well, working with our customers and our partners. But specifically within hospitals and health systems, which is a segment you represent, we did see more commitment to VBC than we've ever seen in the past. What triggered that? What do you think changed in 2024? Was it payer pressure? Was it just general awareness? Was it patient care? What was it trigger?
So I think that in 24, like for our health system, we have about 70% leakage. And so our clinically integrated network is really, we can save money and not reduce our cost or revenue. And in fact, we can increase it because we can bring admissions from other places into us. As you look at some of the other health systems on the reverse side of the equation, where, hey, they've got 70% in system use, I think what they're looking at is the quality aspects, those things that they know are right and good to do so that they can do them. Recoding makes sense. STARS measures, we got to show it. ECQMs, we've got to be able to do it. And so those are the type of things I think drove the behavior. And then just the environment, CMS is going to, I don't want to say push, but maybe I do, is going to push us down that value-based risk world. The payers are pushing us down that world. As your reimbursements are lower than what they were, the only place left to make money is in the value-based arena for now. And so I think those are some of the things that are causing people to get there. And then the industry groups, whether it be forums like this or NACOS or some of the things that the vendors are putting out, we're getting smarter at it. We're getting better at it. So then we're going to do more of it as those things happen.
Got it. Thank you, Joe. And, we are fresh off what was a monumental event, the elections. So just, I was just reflecting on it from a perspective around, if you think about the events leading to the election, what seemed to be a very divisive sentiment, the election results seem to be objectively one-sided. How do you all relate to it? What is the dichotomy of it? And what do you think will be the impact on healthcare at a very high level? I'll start with you, Mary.
The healthcare system right now there's not enough investment in primary care. We know that, right? And that is the best place to put investment, really, because you don't want people going to a hospital system for things that don't need to be handled there. It's just a waste of services. So we have a very fragile system that is, a lot would argue is already broken. We just have to fix it. But the problem that I think the election the problems that it has brought to the forefront is, healthcare, it's a wacky system how we do it anyway. But it's in sort of balance. I mean, it sort of works. It needs a lot of help, but it still works. And the instability that has been created since the election because of the unknown is devastating to healthcare providers. I'll give you a good example. The health center program, there's 1,500 health center programs across the United States in every territory and state. We serve 32.5 million people a year. Our funding runs out in 2 weeks, and we are waiting for the Congress to do something, to somebody make a decision to make sure that we have funding for the next 2 years. And it's and we're just one part of the healthcare system. Everybody goes through this. And this constant need to prove that we need to exist and that we need the funding that helps serve those people that may not be either they're underinsured or not insured at all. It's hugely challenging. And now with concerns about Medicaid block grants, and we just don't know what's going to happen. We can't plan. We can't plan anything. And so to me, that is the biggest issue with the election right now. I'm sure there's going to be more, but that's my big.
And we all, I think everybody on the call understand the importance of the work that CHCs do across the country, Mary. I believe if you think about community care, and that is kind of like the most demanding strata of our society, FQHCs are in the front line. So we are committed. We've always been committed in terms of empowering your mission, your work and whatnot. So we are all hoping that it gets untangled and you have the pathway, the runway. Joe, what's your take on the election?
So a couple different things. Depending on how much you want to give the credibility of some of the folks who will be running this, will we make it to Mary's point around more primary care? Will we do more around wellness and taking care of ourselves versus chasing chronic disease?
Yeah.
Will that make a difference in 2 or 3 years? No. Will it make all the difference in 15, 20 years? Absolutely. And so will that focus change? And it's been somewhat committed to, but until it happens, who knows, right? Then the other one is that CMS as an entity has to find a way to lower costs. They need to stay in business, right? They can't become insolvent. So they got to find a way to lower their costs. And I think ACOs and Reach ACOs and other vehicles like this and Medicare Advantage is what they're going to do. And so I think what we have to do is look at the new models. It's kind of the same as it once was, right? 4 years ago, we kind of know what the old part of that first administration was thinking about. What will the new models be? And really looking at the innovation center and saying, hey, when they bring stuff out, how do I fit in that? And how can I use that? And that's going to be really key. We're going to have to innovate with them and find the good stuff in their models. And so I think that's another one. And then I really think the administration is going to push everybody to more downside risk faster. I think that they have to do that. They want to do that. They're going to push us down there. So we got to be ready for that.
Got it. Himadri?
So I think Joe and Mary already covered a couple of points. One of the things that I was focusing even before the election results came out, Pranam, was what are the bipartisan policies as it relates to affordability, access, and transparency for population health management. And I think there is a interesting phenomena that I'm seeing, which is this is probably the objective of both parties in terms of enhancing continuity of care and access for underserved populations. Both parties kind of in their election manifesto spoke about how they can reduce federal spending and explore more private sector-led healthcare models. I think Mary touched upon this in the past, that when you look at private sector-led healthcare models, then you're kind of able to better ensure technology access in terms of the broadband infrastructure, digital literacy, also availability in multiple languages. We have also done something over the last 2 years or so. We've kind of got an Epic video client instance which kind of helps in bridging the gap for rural and low-income populations through telemedicine, who are essentially, let's say, facing provider shortages or transportation barriers and long wait times. One of the other things that I also kind of got to observe was chronic disease management. There's a lot of talk and an investment that is being spoken in relation to how remote monitoring for chronic conditions such as diabetes or hypertension can be done. And AI systems can alert caregivers and physicians to health risks in real time.
Got it. Thank you. And I think, it kind of leads us into the next segment of our conversations, which is just looking into the future. A new year, there's always this excitement that a new year brings to all of us personally and professionally. But in the almost 25 years that I've been in healthcare, I can't remember a period in time when you are going into a new year with such uncertainty about what to expect in what's coming in healthcare. We can all kind of predict what may or may not happen, but in most, pretty much we are going to get it wrong, right? But especially because we tend to overestimate what will happen in the long term and underestimate what happens in the short term. But given all of that, I would love to hear from all of you on what you think the outlook is for 2025. What should we expect? Mary, I'll start with you.
I don't know that we're going to see huge changes in 2025. I think they're going to hit in 2026 because I think, but I also don't think for the healthcare system that it's going to necessarily if in my circumstance, I think it's going to be the ripple effect of secondary things that I don't necessarily think would pertain to me that are going to happen, that are going to have ripple effects that are going to make a bigger impact on how I provide services. A good example would be, immigration. If they do mass deportations, what does that mean to me as a healthcare provider? What does that mean to me for someone who likes to eat? I mean, there's a lot of of ramifications for just that. And we don't really know how that's going to impact our patients, because I serve a lot of immigrants, and even if they're here in the United States and they don't have any issues, they're terrified. And that means I need more mental health services. It means I need to focus on different things maybe in my health provision of healthcare services. So I'm thinking that's going to be something that we're going to have to deal with. I am thinking, though, the good news is that we need to, in the not-for-profit sector, look at more mergers and acquisitions to become bigger and to be a bigger voice. If you're a little tiny organization, you don't have the bandwidth and you don't have the voice to really push your agenda. So I'm looking forward to that.
And there's been an effort in the last few years to merge and consolidate, right?
Yeah.
Are you seeing alignment in the FQHC space? Because you don't typically see FQHCs go there, because they like the independence, they like the way they serve the community and things like that. Are you seeing more IPA type models coming in where FQHCs are partnering with other FQHCs and non-FQHC providers?
Yeah. Well, we're getting more and more health center programs that want to join our IPA because they see strength in numbers. But there's also, I've been trying to get FQHCs to consider merging for years, because I think we need to be bigger. We're all little organizations.
Right.
It's hard to function, and the administrative costs are high. So you're going to see more of that this year, I think, coming up, starting in 2025. And we're going to need to do that because to Joe's point, when we're starting to do this quality work for our value-based contracts, I know in my communities, I need to have people on the ground talking to patients to figure out how to get them in for care, or for us to get to them to give care. And that takes workforce, and that takes money to hire that workforce. So by merging or working through an IPA, you have a lot more strength to be able to do things like that.
Absolutely. Thank you, Mary. Himadri, what does 25 look like for you?
So I'll talk about 2025 in terms of the what and the hows. So one thing that will continue to be there is the accelerated adoption of AI in healthcare in terms of clinical decision-making, operational efficiency, as well as patient engagement. But in making it realizable, we would probably need more of predictive analytics, as well as some AI-assisted diagnostics that would need to become increasingly mainstream. The second, in my opinion, would be strengthening of value-based care models. And like I said earlier, with the bipartisan interest in terms of lowering cost and improving outcomes, I think that can only happen if we have data systems that are not as fragmented as it is today, and there is more data interoperability. The last bit, Pranam, in my opinion, is probably expanded equity. I think Mary also touched upon this point. I think in the United States, we need more multilingual, culturally sensitive options to diverse populations. And sometimes what does not let this happen is if there is a persistent digital divide, and also, some social determinants of health, such as housing and food security. In order for all of this to be done and done right, I think we would need to address these issues with a very systemic and a multi-stakeholder collaboration, both in the federal space as well as in the public and private sector.
I agree.
Got it. So are you looking at, basically from what I'm hearing from you, you're upbeat about 25 be making more progress in terms of adopting AI, adopting more BBC. Okay, got it. Thank you, Mark.
Absolutely. Totally.
Okay. Joe, what's on your mind for 25?
So for 25, our ACO did an early renewal. We did that for a couple of reasons. One, because we're locked in for 5 years in a model we're somewhat familiar with. Then we can evaluate the CMMI models as they come in and take our action appropriately. We've changed our baseline to 22, 23, and 24 versus 20, 21, and 22, the COVID years. The risk adjustment impact and chronic condition revalidation, we had a big push this year, which hopefully will increase our benchmark. Suffice it to say, for 24, 24, we had to do the things to position ourselves for 25 so that we can be successful. So that's one of the things we're really looking for, is how did these things that we did position us and come to fruition in 25. I think there's going to be a push in 25 to empower ACOs, maybe some less regulations. It's hard to tell. That will come out in 25, but happen in 26. I keep worrying about overall payments from CMS, both from my health system view as well as from the physician view. That's one way to save money, is just don't pay as much. And Mary's talked about that, and it's really important. Then there's things like ECQMs and the percentile-based competition to get shared savings. So ACOs have been this really cool place where everyone could come and talk and improve each other. I worry that if you've got to be in the 40th percentile to get shared savings, does that stop some of that discussion? And I really hope it doesn't, but I could see where someone might take that look at the world. And then the last one, we've talked a lot about AI, and just from a health system perspective, as well as the ACO perspective, I can almost see an AI battle coming in where the payers are using AI to deny us. The payers are using AI to not pay us. So we're going to buy AI from the same vendor to say, no, we need to get paid for this, and here's why, or we need this denial is wrong, and here's why. And the only one who makes money in the middle is that software vendor. But I see that type of thing coming in as we look at our things, and we're a little bit slower adaptive to things like AI, but I can see that really coming in 2025 a whole lot more as everyone tries to learn from it, which I think they spent 24 really learning from AI. Now it's time to actually implement parts of it.
And that kind of postulates the ethical responsibility that the AI solution providers have as well, because you could use AI to manipulate the truth or amplify the truth. The model doesn't care, right? The model doesn't care. It just looks at data and right. So it's even for us, that's something that we are grounded on as well, Joe. Like, how can we be responsible when we figure out data coming from non-traditional sources, and then you convert that into action and outcomes? You have to have a very responsible posture on it. On that same note, all of us on this call, we've been in healthcare for years. We understand the journey that we are all on, and we are all committed to changing healthcare for good in one way or the other. What is the one thing that you all believe that we need to be wary of, could surprise us in an unpleasant way going into 2025, that given our learnings, not just 24, the years prior, what is something that we can be prepared for, we can be better ready for? Maybe it's just better collaboration, better understanding of each other's role in the ecosystem and things like that. Any thoughts on what we should be prepared for or wary of in 25? Himadri, I'll start with you.
Sure. I'll keep it brief because we already spoke about it. And because you asked for that, just one thing, I would probably say that one thing we need to be wary of is not over-rely on technology or AI without the necessary safeguards. It has to be a process-built model with people enablers, and then technology has to supplement all of it.
So you're basically saying have a people-first approach to tech.
Correct. Absolutely.
Okay. Thank you, Himadri. Joe?
I'll say in one word, payers, in that they're trying to, because they have their own financial issues. They haven't made the margins they want. I really worry about what they did on annual enrollment, what's going to happen there. And if they work to get themselves financially secure again, how does that hurt our independent and other doctors make money and stay in business? And so the payers worry me the most, I think, right now.
Thank you, Joe. Mary?
I think the thing that we need to be really wary about is, and I've seen this already, as things get tight, as money gets tight, that sense of collaboration tends to fall by the wayside. And I think that one of the best things that I've seen over the last 4 or 5 years, particularly in our region, but I think across the country, has been a bigger focus on integration in healthcare and bringing together, the hospital and the community health center and the behavioral health people, and really all of us working together to try to give the patient a chance for better health outcomes. And I think that becomes a problem when money gets tight and people start fighting over dollars.
Yeah.
And so it's really important that we keep our eye on the prize and continue to push for all of us to work together. I think that's why, even with our use of the garage and other systems like that, we put all of our energies together to focusing on that patient. And the only way to do that is if we can have a really good opportunity to look at our data and to understand it and to realize that we are so much stronger together than if we all just go our own separate ways.
I want to thank all of you for your amazing opinions, points of view. Every time, whether I've talked to you all as a group or as an individual, it's a learning experience for me. But just like with every Benson episode, we're going to have a Q&A. I think there's some questions from the attendees that I would love all of you to weigh in on. But before we go there, there's going to be a fun question. This is going to be the most difficult question of the entire episode. You guys ready? Okay. All right, let's do this. All right, so wrapping up the year 2024, if all of you look back and if there is one event or episode that you would like to reverse or undo, whether it's personal or professional, what would that be?
I think I can take an attempt.
There you go.
Sure, thank you. And just because you said fun questions, I'll give a fun answer. But because it's in the context of healthcare, I'll probably talk about something in relation to do with my personal health objectives. Joe, Mary, and you are familiar with the fact that next year I'm planning to summit Kilimanjaro. And with such, personal ambitions or quests, it also requires a downtime from work and family, just because the training is hard. Altitude acclimation is hard. The perfect stamina to go for something like this at my age profile is also hard. I think if there is one thing that I could maybe reverse is my age, by virtue of which I probably wouldn't require so many hours of training to be having the perfect stamina or the instant altitude acclimation.
You do need a genie for that. Joe.
The best thing I can come up with is something around Syracuse football. Like if we had beaten Pitt and Stanford, so then we'd be in the college playoff.
There you go.
Great.
Mary?
I don't have anything for it. I agree. Age, it's good that you become wiser, but I don't know if that's always such a good thing.
All right, thank you. Let me look at the questions. There are a few here. I'm going to pick a couple. Mary, I think I'll play this to you. The question is the role of PCMH. What is PCMH? How does PCMH evolve? If done right, wouldn't that be an answer to lowering costs and improving care?
Yes, to an extent, but there's when you have like patients that I serve, I could offer them the world, but if they can't get to me, or if they can access my services, it doesn't matter that I have PCMH certification and that I'm providing services in a particular way. I think that the social determinants that we all talk about have a profound impact on how people can access healthcare. And we have really found that that's where we need to put if we're going to do well with our value-based contracts in particular, if you think about that, because we're PCMH certified at all our sites, and I have a lot of patients that they lack enough to eat, they're in unsafe places, they are unhoused, they have issues, right? And PCMH doesn't always address those. There's that other human factor that everybody tends to forget about that really creates that connection to be able to help a patient. That PCMH just give us a lot of tools, there's no question, but it's not everything.
Got it. Thank you, Mary.
That's a good question.
Joe, there is a question on data interoperability. Basically, wanting to know what solutions has been adopted to solve for interoperability. I thought you would be the best to answer that.
Okay, so I don't think there's just one solution to it. So locally, we have a health information exchange. We got to get the data from there. Bridge does that for us twice a day. Then you have EMR data you've got to get. We have a bunch of independent doctors, so there might be 12 different EMRs, and we got to get that data. And then you have like the ECQM data and trying to get there. So there's lots of different data sources, and that's not to count the public data like you would get for social determinants determinants of health that has to get rolled in, if you're even collecting it. Our hospital, over half the time, we ask the patient the race or what have you, and they don't answer it. And so, you know, obviously you can't push for it, but then your data is half empty. And so even if you have the data, it's not always complete. And so I think data interoperability is a host of things. And really what you got to do is get your strategy. Here's where I want to be 3 years from now, and then figure out the tools to get you there. And versus, okay, where will it be? It's hard to tell, but there's so much out there. You just got to pick where you think you need to be and shoot for that.
Got it. Thank you, Joe. Himadri, I'll post this to you. The question is, I think, around AI in general, but the question is, how do you balance the practicality of innovating with newer technologies that are still a trend or hype and not necessarily proven in the mainstream? So that's kind of, and we could use AI as the example. And we talked about it, but I think it's a different perspective of how do you balance innovation, realizing innovation with something that is yet unproven.
Yeah, I think this can be answered in many ways, but one of the things that we do is for all kinds of new technologies, what we do is a design thinking approach. And a design thinking approach, what we are essentially doing is brainstorming in terms of what is the use case, can it be done with technology, without technology, even if with technology, what are the short-term measures versus the medium-term versus the long-term? How is it going to pan out in terms of the return on investment? And eventually, after all of those milestones or decision criteria have been checked, then we kind of go for a concept prototype. After we go for a concept prototype, we see that, is it only working in the concept stage? If we scale it, would it still give the desired returns as we had anticipated? So those are some of the ways and means in which, Pranam, we bring innovation into play by not doing it in a one and done, but more making it iterative in nature in a very agile-centric approach.
Thank you, Madhu. And there's one new question that just popped. Are there any new programs, public or private, that are being discussed, conceived with outcomes in mind versus services or activities? Basically, are we seeing newer value-based care, alternate payment models that you all are hearing in your conversations with payers, CMS? Is there anything that we should look forward to, be excited about? I think the last 2 years, CMS has announced more than they did in the last 20 years, is the way I see it. Anything that you've heard, even from the payers' perspective?
Raman, in my opinion, no. I think it's kind of getting into a flattening curve after, to your point, all the announcements that have happened over the last 2 years now.
How about you, Mary?
What's been interesting that I've seen is that we're having trouble right now even getting data from our payers because New York State's made some changes with our pharmaceuticals and they've carved things back in and all this stuff going on. And they can still not tell us, where we are with our data. And we're in this we have a new CMS waiver and we need data feeds every month from our payers, and they said we cannot necessarily give you that. We're kind of seeing that our payers seem to almost be backtracking a little bit, that they can't get their rhythm or something. But I think it's because things keep changing. I mean, that's hard.
Got it. Joe, what are you hearing?
So the payers, I think, for 26 will have new models. Right now, they're 25. They're catching up on their underwriting and trying to change that sales cycle for them. And then I think the same type of thing with CMMI. I really think that come July, August, September, they're going to come up with some different models for us to evaluate. The problem is going to be, you have 2 months to look at it, or do you stay in the program you're in? And so, but I do anticipate them coming up with some new models. And I do think hopefully they'll be outcomes based beyond, the premium or the stars, but more, can we really show that we've made a difference? And even if it doesn't lower costs, if you made the difference in someone, especially around social determinants of health, can we show that and get remunerated for it?
Awesome. Thank you so much. I think that's the questions for today. And first, I want to thank all of you for taking the time, and especially our expert panelists. It was absolute fun. As always, like I said, it's a learning experience to engage all three of you. And one of the things that as we go into 2025, obviously we are pumped as the garage, as we are committed to the work that we do now more than ever. I think the time is now for us to bring in real change in healthcare. And this thing that I read over the weekend, which I wanted to share with all of you, is this Swedish physician, statistician, and public speaker. His name is Hans Rosling. He did this TED segment where he basically called us out on being very heavily influenced by short-term events and data. So if you look at data over the long term, you will realize that we are objectively living in the best times that humanity has ever lived. If you think about the situation that was 100 years ago, take child mortality, take income and health, which is two of the biggest economic indicators for any progressive country, or you take deforestation, you take climate change, you take any of the variables that you want to say, are we better off today? And if you think about data from the last 100 years, you will objectively see that we are in a better place. So with that optimism, with that thought, I would love for all of us to go into 2025 wishing for the best, hoping that 2025 will be even better than 2024 for all the work that we do. So thank you, everybody. Thank you for your time this afternoon. Appreciate it. If you enjoyed this episode, make sure you're subscribed to our channels. Episodes will be posted once a month with a variety of industry leaders, and you can follow us on LinkedIn, Twitter, and Facebook as a Garajan. Have a good one.